Good afternoon and welcome to our webinar on discharge processes to assist in progression of care management. My name is Jamie Stigg and I am a Quality Improvement Program Manager and Pharmacist with the Great Plains Quality Innovation Network on our Care Coordination team. Great Plains QIN is the Quality Innovation Network Quality Improvement Organization for Kansas, Nebraska, North Dakota, and South Dakota. We aim to achieve better health care, improved health, safer care, and lower healthcare costs. I'd like to welcome and thank our audience for their participation today. We are fortunate to have representation from a diverse mix of partners and stakeholders from our 4-state region. Today's webinar will be recorded and posted to our website, www.greatplainsquin.org. Please note it will take 7 to 10 days to be able to access the recording. We will field questions after today's presentation. We encourage everyone to enter their questions via the chat function in the webinar, which is located in the panel on the right-hand side of your screen. We will monitor the chat throughout today's WebEx session and share all questions at the conclusion of the presentation. The objectives for today's webinar are to examine and review key discharge processes and roles to improve progression of care management, identify key elements of the discharge timeout process, and discuss key data elements that demonstrate improvement of care management. We are pleased to have two speakers today from Rapid City Regional Health join us. Nita Dunham has over 25 years of experience as a healthcare professional with the past 20 years focused on her passion, which is case management. She is a registered nurse and holds a master's degree in administrative studies with an emphasis on health administration from the University of South Dakota. She is a certified case management administrator and also co-authored the article, A Hospital to Nursing Home Transfer Process Associated with Low Hospital Readmission Rates in JAMDA in 2013. Nita has been in case management leadership for over 10 years and currently serves as the System Director of Care Management for Regional Health. She has served on multiple internal performance improvement initiatives and partnered with the community to improve safe transitions for patients they serve. Andrea Anderson has been in the nursing field for the past 13 years. She graduated from South Dakota State University with a Bachelor's of Science in Nursing. During her early career, she joined Regional Health as a staff nurse on an orthopedic surgery and neurology unit. In 2011, Andrea began her journey down the path to case management, where she currently serves as the nurse manager for care management at Rapid City Hospital. We are pleased to have them speak to us today, and Nita and Andrea, I will turn the presentation over to you.
Thank you, Jamie. This is Nita, and I know I can speak for both Andrea and I when we say it's a pleasure to visit with you this afternoon. We are incredibly proud of the work that our teams have done related to progressing the management of the care for our patients for our organization. To start with, I'd like to talk to you a little bit about regional health and who we are. This is the symbol of regional health, and it speaks volumes to what is at the core of what we do every day. It's essentially a heart and a cradle, and regional health is an integrated healthcare system with the purpose of helping patients and communities live well. The organization has a headquarters in Rapid City, South Dakota. We provide community-based health care in more than 20 communities in 2 states. We have 32 specialty areas of medicine. We're the largest private employer in western South Dakota, and regional health is comprised of 5 hospitals, 24 clinic locations, and employs nearly 5,000 physicians and caregivers. Regional health is committed to the future of medicine for our communities with medical training partnerships, a medical residency program, and we have more than 130 active research studies. Our mission is to make a difference every day in all that we do. In order to do that, like I said, I referenced the symbol that we have. It really does start with heart. Our compassion, the care that we provide to our patients and their families is really important. vision for us as an organization. Our vision is to be one team, to listen, to be inclusive, and to show that we care. We really want to do the right thing every time. In order to do that, the values that we hold dear are trust, respect, compassion, community, and excellence. So like Jamie had mentioned, the objectives of our discussion today is really to review with you some exciting work that we have done within our organization and examine the review of key discharge processes and rules to improve that progression of care management, identify the elements of the discharge timeout process, and discuss those key data elements that demonstrate improvement in care management overall. I want to start with really talking about where we're going in healthcare and where we've come from. We really are transitioning to more of a population health methodology, and a number of us have a foot in each camp. Years ago when I started in healthcare, it was very evident we got paid for volume. That's how our reimbursement was established. We did have fragmented care. We were very much fee-for-service. We treated sickness, and patients really had an expectation that they would remain in the hospital until they were healed. It's much different today. We had some adversarial payer relationships, very little health information technology. I remember the days of the paper chart very fondly, actually, but things have changed quite a bit. And we had a lot of duplication and waste that accompanied that methodology. As we transition forward, we're really going to be reimbursed based on value. So we've got the accountable care. We use a lot of data analytics to drive the changes, which is appropriate. And as you'll see throughout our discussion, we let data drive the decisions that we made. Global payments are more and more prevalent. And as opposed to treating sickness like we used to, we really have a lot more processes in place that foster wellness. And we are partnering with our payers as opposed to our past relationships. And now we have a fully wired electronic health record. I can tell you a year ago as an organization, we transitioned to a new electronic health record, and it was quite the endeavor for our organization and for our community partners. But ultimately, our goal is still the same. We want to have the right care in the right setting at the right time. It just feels like it's much more of a focus than it was in years past. Oops. So then versus now, when we look at this, like I had mentioned before, we really started to get historically paid to keep people in the hospital until they had healed. Our mission really is now to do what we need to maintain maximum health and move in that direction for our patients. When we look at Medicare from 2015 to 2020, our current methodology is really the table that's on the left-hand side, where Medicare, for the Medicare population, is really in the middle of a reimbursement structure. So hospitals, surgeons, home health agencies, our skilled nursing facility partners, we are all the recipients of that reimbursement model. As we move to bundled payments, the hospital is really going to be in the center of that. And I know a number of organizations that have participated in bundled payment projects, and we have as well. And it really does shift the focus of those post-acute care transitions and incentivizes us and really does make us need to focus on those partnerships more and more. So why was Link the Stay important for us as an organization, and why was readmissions important as well? Like I said previously, we really dove into the data. We, at the core of what we were looking at and trying to make sure that we served our communities to the best of our ability, we identified that we had some key things that we wanted to focus on as an organization. We wanted improved quality outcomes for our patients. We really wanted to increase patient safety, decrease risk. We wanted to decrease risk of medical errors, falls and infections. Everybody knows that the longer you stay in the hospital, the higher probability that you can have an adverse outcome, and we wanted to mitigate that to the best of our ability. And the financial risk to the patient. We wanted to make sure that whatever out-of-pocket expenses that they did incur were appropriate. We wanted to improve our patient satisfaction overall. And we all know that long lengths of stay can really stress the healthcare system, along with reducing unnecessary resource utilization. And ultimately, at the core of what started the conversation was really reduction in diversion. None of us wanted to divert a community member away from their families. And if you think about Western South Dakota, the next like-size hospital is about 300 miles away. So when we had to divert a patient, that is a significant impact on that patient and their family, just in terms of travel and going to unfamiliar areas. So that was really a catalyst for our discussions when we started looking at our own data. One of the things that we developed or determined early on that we needed to focus on was our culture. We had a culture change that we needed to make. When we talked about readmissions and we talked about length of stay and care transitions, most of the multidisciplinary team really did feel like that was a case management issue. If we were unable to get the length of stay down where it needed to be, it was a case management process that needed to be addressed. So we sat down and did a lot of education with the multidisciplinary team to get buy-in to the fact that it really does have to take a triad approach. We had tried it for years in a silo of just case management working on these things and did not see the success because we were missing our colleagues at the table for that work. So that triad we determined was really a partnership between nursing, physicians, and care management. And then that was our core team that we needed to have ownership in this. And then we also partnered with our ancillary services such as therapy and any diagnostic departments that we needed. In order to really paint this picture for the rest of the team, we talked about the importance of all of us being in sync and all of us working together. And so I'm going to share with you a video that we used when we were doing education with the rest of the team to help garner their buy-in and to start moving the discussions forward.
Oh, what's going on, Mr. Voss? Biology, Derek. Fair enough. Can someone tell me what happens when a cell stagnates? Okay, no one's listening to me. I will try again. Anyone know what happens to a stagnant cell? What's going on the table? I don't know. Something about cells. Malia.
It's not good.
Did you hear that? It ain't good. People, a cell that is not in motion is not a productive member of the system. It ends up assuming all the other cells are going to pick up the slack somewhere, but they don't. In fact, they imitate the stray cell until basically the whole organism begins to die. Yeah, but you know what? Biology is an amazing thing. And here's the good news. All that decays can be restored. Just hitting anybody.
Like how a cut heals.
Like how a cut heals. Brian, my man.
Yeah, you got one.
And once that cell is back on track, it creates energy amongst the other cells. That's what happens. It starts getting a little movement going. It gets a little rumble. Can I get a little rumble from everybody? Everybody just rumble in your seats right now for me. Just rumble a little bit. Okay, no rumble. That's fine. I'll be the lone rumbler up here. That's what I am. I'm a lone rumbler. But then the cell starts banging into the other cell. And the cells push back and go, hey, what are you doing to me? They hit into another one. Hey, don't do that to me. That's my friend. You don't even know him. You don't know me either. I know you. We work together. Because then they hit a rhythm. All hit a rhythm. And this is the beginning of the restorative process. So now, even if the entire system is close to dead, what happens? Martinez, come on. Give me something. Oh, not today. Oh, no, not in my house. No. Look out, here we come. Don't look at my pant leg, Derek. You're better than that. Right over you. Come on, man. What do you say? If all the cells work together, what will happen?
The entire system was healed. Exactly.
We needed, as an organization, to determine where we could start. We needed to determine where we could start.
I have 3 training sessions a day, so I need pain relief at 4:1. Now I need relief.
As an organization, when we look at this, my apologies, when we look at this, like I said before, we really wanted to start with the diversion. And we wanted to make sure that we were looking at this in a way that really benefited our patients, because we bumped into each other a lot when we were not in sync. And so we identified 7 key things that we really wanted to focus on, and those are listed here. So diversions, like I said, patient bedside rounds. We had done progressive rounds before, but we had not taken that to the bedside historically. Really looking at our discharge transitions and education for providers and caregivers was something that we wanted to do as well. And looking at our physician advisor services and escalation processes, we needed to have those in place, as well as implement a case management lead role was really important. And Andrea will go into more detail moving forward as well. And that discharge timeout really does encompass what we were trying to do with our long-term care facilities. And our SNFs transitions were something that were important for us too. And we'll cover those in greater detail as we move forward. One of the first things that we needed to do was really look in the mirror and try to figure out, as a team and as an organization, what did we want for our patients? First, we started with what do we want for ourselves and our family. We wanted to make sure that we avoided complacency. So we started those conversations with everybody on the team really trying to determine why they went into healthcare, why this was important to them, and what they really motivated them to continue to want to work on this work. So everybody agreed that we wanted well-coordinated, collaborative team approach that delivered safe, timely, effective, cost-effective, efficient, evidence-based care that spanned across the continuum. In order to do that across the continuum, we really needed to make sure that we had appropriate partnerships in place with various other organizations as well in our communities. So as you can see, in January, when we started looking at diversions, we diverted 89 patients in January, February, March. We had a number of diversions. And remember, every time we divert a patient from here, that means that we can transition a patient or family up to 300 miles away from their home communities. And really being able to put a face with a name was important for us as an organization. Now I'm going to have Andrea start talking with you about the rest of the initiative.
Thank you, Nita. I appreciate that. I appreciate being able to talk about some of the programs that we implemented here at Rapid City Hospital. One of the first things that we started to look at when wanting to impact progression of care and length of stay was how are we doing multidisciplinary rounding. Historically, we had held these rounds in a conference room with the physician, the multidisciplinary team, and the bedside nurse. We quickly identified, a couple barriers to that plan. One being it was hard for the bedside nurse to get away from the nurse's station to come over and complete rounds. So the first step we did was move them to the nurse's station with the multidisciplinary team to discuss the patient. We quickly found out that we were missing key players in this process, and most importantly, the very most important key player, the patient. So we moved these multidisciplinary rounds to the bedside. We focused with the patient on patient goals. Included in these rounds are physical therapy, occupational therapy, pharmacy, the attending physician, the bedside nurse, the discharge planning team, which encompasses case management and social work, and really talked about the patient with the patient. What are your goals? How can we get you to meet where your goals are at? And we adopted the motto, nothing about me without me. If we're going to talk about the patient care, to make sure we're including that patient. While doing team rounding, in order to engage the patient, I like to say that we focus on the 3 C's, which is collaboration, communication, and coordination. In another word, the plan for the day, the plan for the stay, and the plan for the way. So the bedside nurse, in partnership with the physician, discusses what the plan for the patient is that day. Are there tests that we're waiting? Are we waiting on certain labs? They then discuss the plan for the stay, which would also include the estimated length of stay or when the physician feels that that patient may be medically ready to transition to the next level of care. The discharge planning team, case management and social work, discuss the plan for the way and anything that needs to be coordinated in that. Some of the things that we consider is what needs to happen to progress care, what barriers do we need to remove, and what are the goals and milestones the patient must meet in order to transition, what needs to happen, and what are the things we can do to prevent readmission. When looking at avoiding delays in progression of care, we really took a different approach to this. As Anita spoke to earlier, it historically had been a case management owned process to looking at patients meeting their goal length of stay. We really wanted to empower all caregivers on the multidisciplinary team that they can impact progression of care. Ways that we discussed with the nursing team on impacting progression of care is early ambulation. We all know it's better for our patients to mobilize as early as possible. We also historically had been case management looking through to make sure, do we have a PT and OT consult or evaluation? Do we need one? And requesting that as soon as possible. Now with the work through multiple disciplinary rounds at the bedside, we often have our bedside nurses asking, do we need a PT consult? Has OT been in to evaluate this patient? Identifying whether or not the patient wears oxygen at home. If they do or don't, completing that home O2 evaluation as early as possible. Evaluating which medications, and this is where we pull upon our pharmacy colleagues to help. If a patient's on IV Bumex, for example, could it be switched to oral, and could the patient be treated in home with some home health support, and what could be done to accommodate that goal? Working with the physician to advance diet as early as possible. One of the other things that we focused on is really avoiding the while you're here syndrome. So the best example of this type of a case is that patient that comes in for pneumonia, and the doctor identifies the patient hasn't had that colonoscopy in a while. Why don't we just fit that in while you're here? Let's keep you one more day, do that colonoscopy, and then we'll get you transitioned to the next level of care. Another thing that we focused quite a bit on is really not telling the patients that they can stay another day if they wish. Here in Rapid City, we have a high tourist population, and we often see patients that are trying to make travel arrangements back home to their destinations. It wasn't uncommon to say, oh, you're not flying out till tomorrow. Let's just keep you one more night. We'll do those discharge orders in the morning. And really working with the entire team, including the bedside nursing staff, to identify appropriate medical necessity for continued stay. Talk with the patient. Identify barriers to transition discharge. What are their goals? What are their barriers to achieving that? Do they not have valid transportation to and from dialysis? Is there something that we can help with potentially getting them more reliable transportation? Another key component to our progression of care and our work on readmissions was implementing a physician advisory service in-house. This is part of our conditions of participation with CMS, that we have a physician advisor that is able to look at cases, determine whether or not they meet inpatient or observation, and also work with the utilization of our resources as an organization and help to sit on our UR committee that looks at, are we utilizing our resources effectively? We initiated a full-time physician advisor role on November 1st of 2017, and they really help to assist in the progression of care oversight. They provide a second-level review to cases, and we have that physician advisor available Monday through Friday, 8 to 4:30, and really partners with the interdisciplinary team. After the physician advisor started, we determined a need to get the physician advisor up to the different units to start looking at patients that have been here for a moderate to long length of stay. So we developed weekly meetings on every unit of the hospital in which the physician advisor and the case management team, along with the nursing unit manager, attend, and they do a deep dive review and talk about every patient who's been on that unit for 3 days or more. One of the most valuable benefits that we've found from this meeting has been the education of the CM team and the nurse management team on the unit from our physician advisor, so that the case managers and unit managers feel comfortable talking to the physicians about progressing the care, talking to the physicians about can that IV medication be changed to oral, and really the education has been the most invaluable piece. As a part of the physician advisor workflow, we actually implemented a progression of care or discharge delay escalation policy. We looked at the different delays that we have as a system and broke those out into different buckets. Some of those delays can be encompassed in external community delays. Another category is home discharge delays, internal hospital delays, patient and family delays, physician delays, or potentially caregiver delays. And this is an escalation policy that's utilized by both the unit managers and also the case managers on the unit as they're reviewing their patients. So an example of a hospital delay that we see is perhaps a delay in getting an echo read for that physician to make a determination on the care for that patient. So as a part of our escalation policy, we have the case managers contact our lead case managers, which I'll talk about in a little bit, to evaluate and go over that case, and then also escalate to the appropriate department's leadership to ask, is there anything we could do to get that echo read sooner? And then also work closely with the physician advisor so that those overall resource concerns can be brought up in the utilization review committee. Another example of a delay would be an external or community delay. So we often see patients coming in that have new traumatic brain injuries or spinal cord injuries, and they're usually here for quite a lengthy stay. What we're seeing as we're trying to transition those patients to specialty rehabilitation programs is a delay in their authorization from their payer to go to that level of care. So we have that encompassed in our escalation policy as well, to escalate that to case management leadership, so that we can have conversations with that payer, or perhaps facilitate a physician-to-physician phone call with our physician advisor and the insurance company medical director. I want to take a moment to talk a little bit about our LEAD program. So what we did here at Rapid City Hospital is we determined the need to really have the hospitalist having some extra support from the case management team. One thing to understand about the way that our program is designed here is our hospitalists are continuity-based, which means that they have a few patients on every floor of the hospital or every unit. So they were having multiple case managers and social workers that they had to interact with throughout the day. So in order to help meet that need, we developed what was called a lead case manager. Our lead case managers are paired with 3 teams of the hospitalist service, and their caseload on average is anywhere from 36 to 40 patients. What they help to do is meet with those physicians in the morning, the afternoon, talk through their patients, and really help to be that communication conduit to the hospitalist team. We established a service line agreement with the hospitalist team, rolled out a pilot, reviewed our outcomes at 30, 60, and 90 days, and we're just finishing our completion of our rollout phase. Another thing that the lead case managers do is really coach and mentor. We have a number of newer case manager and social work members to our team, and they help to make sure when they're going in that first time to have a conversation with the patient regarding a hospitalized issued notice of non-coverage or perhaps another care concern, that they're supported in that conversation, that they have that clinical resource person to reach out to really brainstorm about patients about what their goals can be and about options that we have for our community. So we outlined the case manager lead daily workflow, and encompassed in that workflow is a morning huddle with the team, printing some reports to review their patient load, and then we also incorporated them looking at our observation patients. So they print out a report every morning looking at all patients who are currently hospitalized under observation to see which patients can be upgraded to inpatient or possibly progress to discharge. They meet with the providers in the morning and the afternoon, and one of the more beneficial things to the afternoon meeting is to help the providers identify which patients are stable for discharge the next day or how they could help prioritize the provider's rounds. We also then took a look at transitions management. We identified an issue we were finding with missing orders and lack of communication that could affect patient safety when they transitioned to the next level of care. So one of the things we did was partner with our local skilled nursing facilities and critical access hospitals, developed a collaborative approach to completing root cause analysis, and then we implemented a variance tracking tool, which is a form that goes on every transfer to our post-acute care hospitals. So if something is missing or the transfer did not meet their expectations, that they're able to identify the why, get that back to case management leadership for our ability to track, trend, and try to remove some of those issues. We identified key opportunity areas, which includes communication, accurate discharge orders, and also provider access. Throughout this, we identified that we really have an opportunity to impact safe and timely discharges to our critical access hospitals and nursing home patients. We looked at the process that they do in surgery. For every time a patient undergoes a procedure, they do a timeout. We have implemented a similar timeout process with a checklist for every patient who is discharging to a skilled nursing facility or nursing home. Our social work colleagues here at Rapid City Regional help to make sure patients are, transportation arrangements are made. They also go through this timeout checklist to ensure if we're sending a patient to a skilled nursing facility for rehab, making sure they have an occupational therapy, a physical therapy order. If they're a weight-bearing status restricted patient, making sure we have that encompassed in the orders. So we go through that with a fine-tooth comb. One of the things I wanted to point out on this slide and this checklist is that we've really encompassed the provider-to-provider report, that prior to that patient leaving the hospital, the social workers ensure that our attending providers have communication with the accepting provider at the facility to ensure that that provider knows what to expect from that patient. In addition to that, we've worked with our nursing staff to make sure that we have nurse-to-nurse report that's called to the accepting facility prior to the patient leaving the care of that nurse. The last thing that we want is for that patient to be en route to the accepting facility, report being called, and then find out that there was a surprise for the accepting facility or something that they possibly cannot accommodate.
This is Nita again. One of the things that I had mentioned previously was that we really wanted to dive into the data. Andrea had mentioned the process that we had in place for long-term care, and we can visit about that a little bit more as well. But I wanted to back up for a minute and talk about the data that we had looked at. We have had as part of our culture a long-standing perception that our length of stay opportunities were solely driven by people that needed to discharge to long-term care, but we did not have placement. So one of the things that was kind of an aha moment for a lot of people was that our largest opportunity was in actually people that discharged straight home. So Andrea had mentioned some opportunities that we had to dive into those, and that the providers would want continued hospital stay for patients, but we did also have a significant issue related to our long-term care access. So one of the things that we did related to provider access was simply in our community, we did not have enough providers who were willing to follow in our long-term care facilities. A lot of our clinic providers were either retiring or they were just not interested or not able to accommodate the expectations associated with caring for patients in the long-term care environment. So our solution as an organization was to create a SNFist program. So our SNFist program is actually comprised of a group of our hospitalists, and they serve as the medical directors for some of our long-term care facilities in the community who did not otherwise have a medical director, or their medical director wanted to transition and focus more on the clinic setting. When we were looking at doing that, it really gave us the opportunity to develop partnerships with our long-term care partners. One of the first things we did was determine communication expectations. So we needed to establish kind of that one-stop shopping for people when they were looking for a provider to follow in a long-term care facility. And we wanted to be respectful of our community providers as well. So the first thing we always asked our patients and families was who their primary care provider was. And then we would validate whether or not that particular provider was able to follow them in the long-term care setting. And if they weren't, then the social workers could make a single call to our SNFist program, and there was a coordinator in that program that would link them with a provider. This saved a tremendous amount of work for our social workers, as well as saved our community providers from having multiple calls. So we did education with the social workers and the case managers regarding what that process was going to entail, and it was unanimously appreciated by all. So that went really well. We also decided that we needed to, as part of building that partnership, have routine meetings with our community partners and facilities so we could determine what additional opportunities that we had. One of the things that we created as far as our routine meeting is the Geriatric Forum. So to give you an idea where the Geriatric Forum came from, our rules and regulations in the hospital setting are markedly different than our long-term care facility partners. And we had to develop a platform where we could explore those differences and also determine the similarities and determine what opportunities we had moving forward. So an example of something that we addressed in the last year at this Geriatric Forum was when we started to see more CRE patients in our hospital setting and in our state. So what we did was we had a representative from the state Department of Health come in and do education with at the Geriatric Forum, where we had all of our medical directors, directors of nursing, and MDS coordinators are welcome to come. Whoever else works at the facility, social services, they can come depending on the topic. But they all came together with our SNFist providers and our infection control colleagues and really talked about what does that look like for a CRE patient to make sure that we have a safe transition. We discovered that our infection control practice requirements in the hospital setting are quite different than they are in the long-term care environment, so we needed to explore that. Another topic that we've discussed, like I said, we went up about a year ago with a new electronic health record. We had a lot of work that we needed to do related to that to make sure that our discharge orders met their criteria, that we were meeting the pharmacy regulations that they had in place. And so the Geriatric Forum has really been a catalyst for creation of additional small work groups to make sure that we are really improving and streamlining the process of transitions for the patients that we serve in our communities. So when we look at our outcomes, this is exciting to me. We look at our length of stay as an outcome over expected. So those of you that are familiar with DRGs, the DRGs have a length of stay associated with each one of them, and that's the expected length of stay based on the diagnosis for that patient. And then we have our actual length of stay. How long does it truly take us to treat a pneumonia patient or a COPD patient, and so on. So theoretically, when you get to the 1.0 ratio that we created when we compare those numbers, the 1.0 really means that we are discharging patients at the same time that the DRG would, on average, expect them to be discharged. So our goal is really to hit that 1.0 range or optimally based on our patient populations. we started our endeavor when we were looking at this at a 1.36. And I am very happy to say in June we finished at 1.03. So we really had made a significant amount of progress in reducing our length of stay in a relatively short time frame. To put this in a length of stay perspective, aside from the ODE ratio, our length of stay when we started on this journey was 6.02. We finished June at 4.4. That is a tremendous reduction in length of stay, and it's just another metric that we look at. We've decided through lots of conversation that length of stay is really an outcome of the processes that we have in place, and so it's one of those outcome metrics that we wanted to monitor. The ODE ratio pulls into place the DRGs and the case mix index calculations for our patients as well. So we do monitor both metrics. This information really came from the Quality Innovation Network. They were asked to divide the state into regions. Rapid City is in Cohort B. So this is South Dakota Cohort B, relative improvement rate, hospital readmission for 2017 and 18. The goal is to have a 5% relative improvement rate. And as you can see, when we started our length of stay work, our readmission, we had opportunities to improve our relative improvement rate. And as of January, February, and then March, April, and May, we surpassed the 5% improvement, which was wonderful. When this report was pulled, there were no other cohorts in the state that had reached this goal. So we're very proud of that. I had mentioned previously that when we looked at our length of stay data and our readmission information, we really wanted to pay attention to patients that just simply discharge home. That patient population, just by sheer quantity, had the opportunity to have a huge impact for us as an organization. We have historically kept patients an additional day for that one more diuretic, one more antibiotic, that one more blood pressure, and we found that those are the patients that typically discharge to home. And so as we started to use our escalation process and our bedside rounding and tap into our physician advisor to change that culture, we started asking our providers, what would make you comfortable discharging that patient today if you feel like they'd be stable to go tomorrow? Is that something that we can help with? Is it a barrier we can overcome? And we started to move that mindset and that philosophy. But in doing that, we wanted to make sure that we paid attention to our readmission rates at the same time. As you can see in this information, we did show an improvement in our readmission rates across the board. So not only did we decrease our readmission rates for our nursing home patients, but we also decreased our readmission rates for our home and home health discharges as well. The last number of months, hospice hasn't showed up on the data collection either. So with that focus in all of those areas, the outcomes have been great for us as an organization. We're very pleased. So next steps, because we're never done. One of the things we want to make sure that we do is sustain. Sustainability is huge. When we are trying to make a culture change, we need to make sure that the new habits that we have in place and the new processes that we have in place are hardwired. So one of the areas of focus when we look at progression of care is we're looking at mobility and what nurses play in the mobility of our patients. Mobility in the hospital setting is not just a physical therapist responsibility, it's the nurses on the units as well, so we're focusing on that. Our next large collaborative is going to be surrounding the discharge process, where we're really drilling down the entire discharge process from the time the patient is admitted until they discharge. That takes into account how the patient is registered. Do we have the appropriate next of kin? Do we have an accurate medication list? And then all the way through to discharging, and how are we doing our education at discharge? Are we setting those follow-up appointments? Are we doing teach back? What does that look like? And it's another aspect of all of this that's going to impact our readmissions and our length of stay as well. So we're very dedicated and focused on that work at this point. The other thing that we're developing is a readmission steering team. We have, with our new medical record, the ability to identify the reason for the risk of readmission. So if the reason for the risk is polypharmacy or if it is frequent ER visits, our readmission steering team is going to get together and look and see what interventions do we as an organization feel are important to have in place based on the identified risk for each individual patient. Some of those interventions may be that we want to recommend a home health consult, maybe we want a pharmacy consult. We may need a home evaluation by occupational therapy to make sure that people are safe, but that's the next bucket of work that we are going to do. And then we've also embedded case management within our SNFist program. I'm excited about that. I think that will really help with our nursing home readmissions. So what that entails, our SNFist program follows about 180 patients currently. About 40 of them are skilled patients that are there primarily for short-term rehab. So the case manager is going to follow those 40 patients that are skilled and partner with the providers to act as that liaison to determine what opportunities we have for follow-up visits. Are there educational opportunities that they can partner with the directors of nursing to provide additional education for the nurses at the long-term care facility related to congestive heart failure signs and symptoms, things to look for, and really help everybody grow in their critical thinking skills from a nursing perspective with those physician partners. So those are the next steps for us as an organization related to that. I can tell you that it's been quite the journey for us, and we continue to move forward. Jamie, I will pass this back to you for any questions.
Thank you, Nita and Andrea, for that great presentation and for sharing the great interventions and great work that you've been doing within your facility. I want to remind everyone to please, if you have questions or comments, to please enter them into chat, which you might have to move your mouse to the lower part of the screen to get the menus, and then there's a little speech bubble thing that you can click on to show chat, and then chat will show on the right-hand panel. I don't see anything in chat right now regarding questions, so everyone's been so in tune to your discussion that we haven't had any questions to ask. It sounds like you've been on quite a journey. Were there any particular barriers when you did, or I'm thinking back to the video that you showed and how everyone had to get to work and get movement within the system. I'm curious about did you have any challenges with that, and what did you do to try and mitigate those?
I think one of the things that we struggled with at the very beginning was that everybody was trying to do the right thing. We just happened to be very siloed in that process. So everybody thought they were doing a good job and they thought they were doing the right thing for the patients and providing the services that their specific specialty provided. But we weren't all doing it in a coordinated effort. And I think that was the key part of it, is when we started to identify that we were better as a group than we were individually, that really helped us. It was a mind shift and a culture change, though.
Yeah, thank you. One question that we had in chat is how long does it take for bedside rounds on average?
So this is Andrea, and that's a great question. When our team first started rounds, it was much more lengthy than it is currently today. As the team got more as a higher functioning team that moves through the patient rooms, one thing to keep in mind is that these rounds from the physician's perspective is not when they do their head-to-toe assessment of that patient. They don't do their formal assessment. On the same token, it's not when the case manager is doing their assessment about specific discharge needs and specific support at home. I would say that it takes about an hour for 16 patients, but we upfront the plan for the day during rounds So it actually offsets the pharmacist's time in researching things, the case manager's time in getting through the chart, and also helps save the physician time with having everybody on the same page with pages later on in the day.
Great. Another question that was asked is, can you speak more specifically about how you utilize pharmacists for the transition process? Explain how you used pharmacists at the point of admission to actually help improve the discharge process.
We have med-rec techs that do assist us in identifying that home medication list and partnering with pharmacy. We actually have the case managers on the units. They do a lot of office sharing with pharmacy, so if there's any issues or questions that come about, everybody is geographically located in the area, the patient populations that they serve. So by default, they have a lot of ready access to one another, which has been very helpful as well. We also have a pharmacist that we work with very closely on our SNFs transitions, and that work group that we put together to look at our discharge process when we went up with our new medical record a year ago. Their insight has been crucial to determine how medication prescriptions, that preferred pharmacy aspect of it, and the regulatory requirements. So we tap into our pharmacy colleagues on a regular basis. We also, if we have patients that come into the hospital and they have altered mental status and we're not quite sure, we can't find the etiology of that, our first consult is to pharmacy to look at their med list and see if maybe they're on a medication that they can identify that might help our providers. So they're very well respected amongst the team and pulled into a lot of conversations.
Another question is, what is your ratio for case management social workers to patients?
Our case managers here at Rapid City Hospital have anywhere from 16 up to 22 patients or beds that they follow. They are located geographically. Our social workers cover one unit of the hospital, so on average they may follow, somewhere between 32 and 48 beds, but they are only consulted on patients with complex psychosocial needs, but they do attend our bedside rounds for the patients that they're not consulted on as well.
Okay. It looks like that's about, looks like we had another question regarding pharmacists and reducing readmissions, but I think you hit on that unless there's anything else you want to add to your previous answer.
One of the things I wanted to add is how pharmacists can be beneficial in that multidisciplinary team and rounds is really helping the case managers and nursing department to identify medications that could be costly to patients that are discharging, because the last thing we want is for our patients to show up at their home pharmacy and not be able to afford the medication that they're being discharged on. They also help us looking at, is this for medications that make the patient more successful in the outpatient setting.
Okay. And we have a follow-up regarding the ratios. It was asked to please address how many case managers and social workers you have to assist on each unit.
So the case managers and the social workers are geographically based. And the way our hospital is set up, like Andrea said, the average caseload for the case manager is about 16 patients or so, but they are geographically based on that medical unit. So they partner with the social workers and the rest of the team. We used our survey results and tried to determine what the appropriate caseloads would be, but we do take into account the patient population. So for example, our medical patients sometimes need more social services assistance than someone that's a surgical patient. So the caseloads are adjusted accordingly based on the acuity of the patients as well.
Thank you.
Yep.
All right, I will put out one last call for questions. If there are any other questions, please enter them into chat now. Okay, well, thank you so much to Nita and Andrea for your presentation today. We ask all attendees to complete the evaluation form for today's event to offer us feedback and help us plan and coordinate future events. We want to ensure we are meeting the needs of our partners. Your input is important. Please use the evaluation to provide us with feedback on the types of topics you want us to address through this upcoming series. The evaluation will appear when you exit today's webinar. Please contact the Great Plains Quinn Care Coordination Leads with any questions you may have. Thank you so much for your participation today. We hope you found this information valuable and applicable. We do have one last question that did come through. What title does the physician advisory hold?
Our physician advisor is called that. It's a physician advisor. We had created a job description. We also have an external physician advisor that we partner with, but the job title that we found most prevalent across the country was to simply call them a physician advisor. He reports directly to our Vice President of Medical Affairs through the Medical Staff Office. And
that is
yep. It's a doctor. Yeah. It's a physician. And, you know, in part, with the case managers, we know our world from a nursing perspective. It really does add a lot of value for us to be able to tap into our provider to be able to look at a case and say, do you feel like this patient is medically stable for transition? Am I missing something? How can we have that conversation with the attending if we don't feel like we're getting the progress that we need? So he provides that service not only to educate and coach our physicians or his physician colleagues, but also our case management team. We've seen a lot of growth in just their clinical knowledge, being able to have ready access to a physician to help through those conversations.
Great. Thank you for answering that. Once again, thank you everyone for participating. Please complete the evaluation that will open at the end. This will conclude our webinar. Thank you all for attending.